Hello again to Healthy Brain and Mind. My name's Dr. Aaron Menon, and apologies for the last few days. It's been quite busy at the Menon household, but hopefully now I can provide more regular content and keep to a more regular schedule. This video today is just a general video on psychiatric medication. I will just go through the main types of medications and why they're used. And in the future, what I'll do is I'll do some more specific videos on specific types of medications to give a more in-depth, to give yourselves a more of an in-depth knowledge on them. Now, psychiatrists use a number of medications, but it is not necessarily the first choice therapy for those that attend to the mental health service. For a lot of people, talking therapies would be the mainstay of their treatment, or even nothing at all, nothing health related at least. So for many people who are in the mental health service, medication may not actually be the answer or be an only partial answer to treatment. For a lot of people though, particularly with those with severe and enduring mental illnesses that are predominantly biological in its nature, so to speak, then biological therapy is required, as in medication. There's a number of different types of medication used, and I guess I'll broadly classify them into four main groups. We've got antidepressants, anxiolytics, anti-anxiety tablets, antipsychotics, and mood stabilizers. There's a number of other drugs out there that work in different ways and don't fit comfortably in any of those four main classes, but I'll talk about these four anyway first. Now, with antidepressants, there's been a lot of progress made over the last 20 years, and I guess it's kind of ballooned within mental health services and particularly amongst GPs and family doctors. There's been a class of drugs called SSRIs, selective serotonin reuptake inhibitors, which works on the serotonin molecule in the brain, which has got strong links to mood disorders. And there's been many antidepressants made for the serotonin molecule, particularly Fluoxetine, Prozac is one of the brand names, citalopram, and sertraline. Previously, there was much older antidepressants called tricyclics, such as amitriptyline, which is still now used, albeit less so and more for nerve pain treatment. There's a number of others as well, but they've kind of gone out of fashion, mainly because of its safety profile. With tricyclic, the older antidepressants, they were more dangerous if somebody took it as an overdose. SSRIs are still dangerous if taken above its recommended doses, but it puts patients in a less vulnerable position compared to the older antidepressants. They're very useful, and if used correctly, very effective in treating people's depression. The only downside, I guess, would be the fact that it takes quite a while for these antidepressants to work. You won't just miraculously feel better if you started taking them on the first day. People tend to notice maybe some initial benefits after 2 weeks if it is working, but we tend to wait for about 6 to 8 weeks before we even decide whether an antidepressant is working or not, which is quite a long time. And obviously, if you're feeling particularly depressed and tormented by your low mood, it's a terribly long time to wait to know if an antidepressant is working for you or not. On the another plus side, though, is that contrary to many people's fears, it's not typically isn't an addictive drug. Some people can be, I guess, psychologically addicted to it, so to speak. If they've been taking an antidepressant, they get better, and they've required long-term antidepressant therapy. There's always going to be that understandable, quite rational fear that cutting down or stopping it will cause a relapse of illness. Most people do have to be on it for a long time, though, and that again kind of brings the illusion of dependency. People will have to take the antidepressant, and if it works, they'll hopefully get better. And then they have to stay on antidepressants for at least 6 months before you even consider stopping it. So it's quite a long time to be on antidepressants, and that's evidence-based medicine. There's research to show that if you stop antidepressants earlier than that, there's a significantly higher risk of relapse of illness. So that's why we do recommend, if somebody is using antidepressants and responding to it, that they continue it on a fairly long-term basis. Nevertheless, if somebody does get better and they've been on it for enough time, reducing it and stopping it would be the most appropriate thing to do. So it's by no means lifelong, unless, of course, the illness is so severe or has high risks of relapse that it's just a requirement. Thankfully, antidepressants don't cause too many long-term problems. In the short term, you can have side effects like maybe gastrointestinal upsets, changes in bowel habits, or headaches, blood vision, or dry mouth. These things are not that common, but can happen, and are usually transitory. So people who start on antidepressants may suffer these symptoms, but they tend to settle down after a short period of time, days, usually. If they're persisting, of course, then maybe it's worthwhile looking at whether the antidepressant is the right one for you, and maybe an alternative is a most appropriate thing to do. And it's also important, as you might imagine, like with all psychiatric medication, is to continue them consistently for the benefit of the medication, to make sure it's working, and also so that we as clinicians can understand whether it's working or not. It's very hard for us to work out whether a medication is working if there's stopping and starting for whatever reason. Usually very unreasonable reasons. So that's antidepressants. There's anxiolytics, which are to help treat anxiety. This is one of the more controversial classes of medication, really, in a way, because it's predominantly was dominated by the benzodiazepine class of medication, the likes of diazepam, Valium being one of the brand names, amongst other medications like temazepam as well. They are very good at what they do, actually. They work on a few molecules in the brain, GABA and such like, and glutamate. But they have the main problem with them is that they are addictive if used at higher doses and for prolonged periods of time. So what clinicians usually do is we recommend that these types of medications, if it's one of the benzodiazepines, is used on a very small dose and for a short period of time as possible. If it's required long-term, then it's required long-term if no other alternative seems to suppress anxiety, because ultimately, if the anxiety is debilitating, it's not a very pleasant thing. It's probably one of the worst symptoms anybody can really have, actually. And I think any clinician would completely empathise with the fact if somebody is suffering from that anxiety, that they would like something to get them better sooner rather than later. And speaking of which, that anxiolytics tend to work sooner rather than later. It doesn't take a number of weeks. Particularly with benzodiazepines anyway, they work within hours, minutes and hours actually. Some of the other drugs that are used may take a bit longer to work, but they have a longer term effect and therefore don't require just that regular use of the medication. But they are something that should be carefully monitored by doctors, and people should ideally not be left on them as they might have been done in the past, actually. Antipsychotics, mainly used for schizophrenia and other psychotic illnesses, though can be added to people with mood disorders as well. Predominantly work on molecules including dopamine, but also on numerous types of molecules, actually, and there's a number of different classes of antipsychotic out there that work with varying degrees of influence on these different molecules. Antipsychotics have been around since the 1950s, and some of the older ones are still around, such as chlorpromazine and haloperidol. But there are newer ones that have been coming out, such as olanzapine, risperidone, quetiapine, aripiprazole as well, which are just as effective as the old ones, but have a lower side effect profile, and don't seem to be so much of a problem if used on a long-term basis. These medications tend to be used more long-term in psychotic illnesses, particularly, mainly because psychotic illnesses tend to be a relapsing remitting type of illness which requires long-term therapy and doesn't just go away by itself, although it can in some cases. They have side effects, and it varies between drug to drug. Sedation can be a common one, for example. Similarly, bowel disturbances as well, and but they vary between the drugs. So I'm not going to go through the specifics by any means in this video, But it's important for clinicians to realise that, whilst these drugs can be effective in treating the psychotic symptoms, if somebody is unable to function at a reasonable level whilst being on this medication, impairing their abilities to do day-to-day things or driving, or just making them overly sleepy, then the timings and the doses and the actual medication itself has to be reviewed, of course. But they are very good at what they do, and as I say, they can be used in combination with other medication if necessary. For example, with antidepressants, if somebody is struggling with a treatment-resistant type of depression or is having quite severe depression with psychotic features. Similarly with mood stabilizers as well. Now, on mood stabilizers, they're predominantly used in bipolar illness. The gold standard for that is lithium, which has been used for decades now. I guess you don't have to call it a drug, really. It's more of a salt. It is just simply lithium carbonate, typically, or lithium citrate sometimes. And it treats manic episodes very well, and it helps people maintain a reasonable level of mood in the long run. The issue with lithium particularly is it has what we call a narrow therapeutic index, which essentially means that if you take a little too little, in a way, it doesn't work as well. And if you take a little too much, it can be potentially quite toxic. And if you take away too much, it can be potentially fatal. So with that narrow range, and we have to do blood tests every so often, more frequently when somebody starts it, to work out the most appropriate dose for somebody to be on it and to keep them on that dose. And being a salt as well, it's mainly it doesn't change in the body when it enters into the bloodstream, but it's excreted by the kidney, so we wee it out basically. And if somebody is dehydrated or drinking too much fluid, or if it's a hot day and these kind of things, you have to be careful about. You have to keep in mind at least what that might be doing to people's lithium levels in their bloodstream, and hopefully people don't get too dehydrated that leads them to have higher levels, for example. There is other mood stabilizers out there, and they're predominantly anti-epileptic medication. These are again equally effective, well, almost as effective, I should say, as lithium. Lithium, as I say, is the gold standard, and are useful in combination with lithium or with each other as a means to control and treat and control bipolar illness. They are useful in a number of ways, but there's one drawback that clinicians particularly have to be remembering, and that is it can affect mothers during pregnancy. If any woman who's on anti-epileptics and mood stabilizers in general, and actually lithium as well for that matter, and are planning to become pregnant, then they must speak to their doctor about it. And doctors should themselves ask childbearing females if they are potentially pregnant at the time of commencement of any medication. And if somebody is choosing to become pregnant and have a bipolar illness that has been treated by mood stabilizers, then people have to think about whether about stopping the medication or at least reducing the dose, and weighing up the pros and cons about continuing medication during pregnancy if it's felt it's necessary. But it does lead to potential congenital defects in children, particularly in the first and third trimesters. So it has to be well monitored if it is to be used, and under expert supervision, to be honest. Otherwise, most people would recommend that it is stopped. An alternative treatment considered depending on the predominant symptoms of illness that led to them being on the medication in the first place, and quite close monitoring too. So that's essentially the main classes of medication. There are other things, including things over the counter. There's certain herbal medications that are still in use in a way. St. John's wort would be the most famous of the herbal medications that is used as an antidepressant. But even though they're over the counter, remember they're still drugs, and you have to be wary, like with all drugs, side effect profiles, its efficacy, and also interactions. And interactions are very important in psychiatry because all these medications that I've described can potentially interact with other medications, and therefore anybody who's seeing a doctor about this needs to be able to tell them, or if they're not the usual doctor, what medications they're on outside of these types of medications, because they can either positively or negatively affect the levels of drug in the body if it's prescribed, and vice versa for that matter. The psychiatric medications can have an adverse or a positive even effect on currently prescribed drugs. And also another thing to note is anything that affects the body, so any sort of illness or any function of particularly the liver and kidneys, if these are impaired in any way, then the drugs will affect the body in a different way, and that's the same for any drug that is prescribed, not just in psychiatry. I mean, I guess things in particularly mental health is if people are struggling with substance misuse, particularly alcohol misuse or any other recreation drugs, then that will have an effect on the liver, as you can imagine, and therefore the effect of the drug prescribed may differ because of it. Similarly, smoking as well. It's noted that people who smoke tend to require higher levels of antipsychotic medications, for example, than those that don't, because the way that cigarettes kind of inhibit the breakdown of the antipsychotic medication in the liver. Or, sorry, apologies, they actually induce greater breakdown of the molecule, the drug in the liver, so therefore there's less of it available in the body. So hopefully that was a useful general guidance on medicines used in psychiatry. As I say, in the future I'll go through some of these classes and maybe specific medications more in depth in future videos. But as a general rule, I hope this has helped you understand why psychiatric medications are prescribed. If you felt this was a useful video, then please like, subscribe, follow, do the usual things that you might do on YouTube, and I'll continue to bring more content on a regular basis. But for now, thank you for listening, and goodbye.